Welcome back to the American College of Surgeons Bulletin Brief from the Frontline Surgeons Voices. And back with me today is my friend, Dr. Frank Opelka. We've spoken with Frank recently about many of the initiatives that he and the rest of his team have been successfully conducting on our behalf, more appropriately on behalf of our patients in Washington, D.C. and throughout the country. Today, we'd like to chat a little bit about where we're going more long term in terms of quality programs and how the government payers will be able to assess performance and make decisions based on the data that already exist, how those data can be used, and where the American College of Surgeons fits into creating the future of healthcare payment system and healthcare quality metrics. So, Frank, why don't you start out with that rather broad subject and give us your reflections, please?
Well, again, thanks for having me. It's great to be here, and I appreciate the opportunity to have the dialogue, Steve. So this is wonderful. Um, yeah, I think you're raising an interesting point that as we move from where we are with the fee-for-service into a value-based contracting, insurers want us to take more and more risk. And as we take risk, you can't take risk blindly. You'll ultimately fail if you do. So we need to figure out how are we going to use all the tools in front of us to leverage those tools for optimal care and really reduce our risk, reduce the patient's risk. Um, and so that whole field of science that's now emerging exists in other industries. It's now being applied in healthcare, and it's often referred to as knowledge engineering or knowledge management. It's what Google does. It's what Amazon does. They take reams of data so that every time you click into Amazon, they know how you shopped last time and they can offer you whole new things that might be of interest to you. Well, what if I applied those same analytics to all we know in a digital services world of healthcare? Now that I have EHRs, what would happen? And so that's where really this is going. And it's caught the interest of the government. The folks in the government who are playing in this game, the Agency for Healthcare Research and Quality, ARC, CDC, CMS, ONC, the NIH, they all realize that we now have, through EHRs, through smart devices, like smartphones and watches and implantables, we have an enormous amount of knowledge coming in. And as that knowledge comes in, how do I apply analytics to it and then expose it back to you, the surgeon, in a meaningful way that you can then take it using your expertise and working with the patient, take them to another level of care. An example you and I've talked about is it's one thing to measure whether the antibiotics went in on time. It's another thing to take the predictive analytics and analyze a patient and predict their outcomes, predict their short-term outcomes from a surgical site infection, or predict their long-term survival outcomes from the therapy you're giving them. We are starting to get that much information in the healthcare system. So that's kind of the high-level view of where this is going.
Would you envision that the NISQIP risk calculator would be a foundation for some of this information?
It's certainly a key player that it provides. NISQIP itself allows us to analyze millions of patients, and based on that, we can determine what factors are the key predictors to outcome. And then you use that in a predictive analytics manner using things like the risk calculator. And then a surgeon can lay out for a patient, this is the operation we should think about, but given your circumstances as a patient, we can personalize your risk. And so now you're imparting that knowledge to a patient, but you as the surgeon, you're still the source of truth. It's one thing to have data in front of you, but somebody has to look at it and say, are the data I use reliable? Were the outcomes that we predicted and the analytics applied valid? And that's where the College of Surgeons comes in, and all the medical specialties. Somebody has to look at the algorithm that's being applied and say that this algorithm was the best algorithm. It had the closest chance of truth. It's tracked for opportunities to improve the algorithm on a regular basis. In other words, it's one thing to engineer the algorithm, the knowledge, but it's another thing to govern and manage it long term. And it takes subject matter experts. That's not going to come from Blue Cross, or it's not going to come from the government. It's going to come from the subject matter experts in the field.
And I recall that Cliff Co. has shown us in the past that the fidelity, reliability, reproducibility of NISQIP outcomes exceeds that of other databases. And I'm not sure if you would care to opine on that theme.
So certainly the foundational structure of NISQIP and of the, even in cardiac surgery, of the STS database, these are built on standards with overwhelming rigor. It's where the cost comes in. If you don't invest in creating rich, lush, trustable data, you'll actually end up with outcomes that will mislead you. And that's where NISQIP actually makes its biggest investment. It's in the integrity of the data. And that then translates into more reliable and valid knowledge management at the end of the day. It's unbelievably crucial.
How is the college viewed by all of these various organizations who were referenced by you a little bit earlier, by the NIH and CMS and the like, as they try to figure out where the pieces in this puzzle belong to get more reliable data to do predictive modeling?
At first, everybody relied on things like claims data. It's readily available. It's much cheaper to get, but we've been able to demonstrate as the college that these data are not actually trustworthy enough for imparting medical decisions. They might work in a payment plan, but they don't work in a care model. So we are really probably among the one or two, three specialties considered true north on how you leverage clinical knowledge in such a way that you can use it in a digital environment and begin to expose it for better care. We're not there. We're at the beginning. We're almost at the end of the beginning, but we're not quite at the end of the beginning. But now that we have the technology coming to us saying, we're ready for you, and we have the analytics saying, gosh, if we only had the subject matter experts in the room, and here we are. The college is a primary leader. There's a couple others, cardiology, emergency medicine, but they're coming slowly, and they're starting to realize that our role as the subject matter experts in knowledge engineering and knowledge management is crucial.
Well, thanks to the work that you've done and that Cliff has done, and everybody else involved in quality programs and in healthcare policy and advocacy, we are recognized now, as you say, as the subject experts, and people are coming to us, and that's great. But speaking of people, do you envision that this type of platform or these types of platforms would also be accessible to patients and might form part of the patient's decision making as they're deciding where to go and to whom to go for their care?
I do. This is an interesting policy and legal debate that's very alive right now. Who owns all these data? And we contend as the college, the data really belong to the patient, and we're using that data to help them deliver better healthcare. When you talk to the electronic health companies, the vendors for the EHRs, they believe they own the data and they want to leverage the data and be the be all and end all in how the data are ultimately managed and engineered. I think this is going to come down to a real legislative challenge for the government to face. And I think those of us as physicians say that, knowledge is the new currency. And how do I provide my patient with the knowledge they need to optimally manage their care? How do we have shared knowledge as a group of clinicians caring for a patient? And it shouldn't depend on who owns these data. And the systems exist now to make the data owned by the patient. The real challenge is that as we look at HIPAA and privacy, how do we actually create a structure that protects data using something like blockchain, which is being considered so that the patients can own their data. But until we have secured privacy, it's hard to turn the data over to anybody outside of where it currently resides.
You mentioned government, and we're the American College of Surgeons, but we do have a very large constituency and a rapidly increasing constituency of fellows from overseas. Many of these fellows are in countries which have a single payer system. Some of them have much smaller populations. Are you aware of any initiatives outside of the US in other countries where this type of a platform is further along than it is here in the US?
Great question. We do have some knowledge. There are several countries in Europe, also Israel, where there are huge efforts in exposing knowledge artifacts that can be better leveraged for better healthcare, and they're making incredible advances. Um, and we've got challenges in our system. The way we're set up, we're so large, and we have a lack of true interoperability to really use and leverage data. It's hard to imagine, but a patient, when they undergo a surgical procedure, they may touch 6, 7, or 8 different EHRs around that patient for that procedure. How do we bring all that together in a meaningful expression of knowledge so the entire team can care for the patient? And that's what's happening in some other nations around the world, is they are looking at the same opportunity and leveraging it for better healthcare. I think I've seen the most advance in Israel, but I'm not aware of all the fine nuances in other places, such as Switzerland or Sweden or the UK. I do know there's a lot of activity going on.
So the last question I'll ask, the college is the great convener, and the college is always the head of collaborative efforts. Do you envision any collaboration between the college and another organization, or among the college and multiple organizations from other countries to try to solve the problem or to share best practices?
There are several international organizations that are forming, things like HIMSS, and we are increasingly playing a role at the HIMSS meeting. There's another one, the Object Management Group, which now has a healthcare division. The college is a member of that collaborative effort, where we use our ability as subject matter experts in any environment where there's open source. We don't want to get lost behind a proprietary firewall. So we have been promoting the open source architectures in places like HIMSS or the Object Management Group in something called BPM Plus healthcare. So those efforts are ongoing. And here in the US, we're doing some of the same with other specialties and the Council of Medical Specialties. And we actually have in November, we've got an upcoming symposium about knowledge management, knowledge science, and digital services. So we are I would say, a major driver in pushing those collaboratives for how we actually learn from each other.
Thank you. Any other parting comments you'd like to leave with us before we conclude?
Well, it's just been great to have this opportunity to talk to you first about quality and where that's going, and then about cost and price and where that is, and understanding this concept of value and shared risk, and helping see how knowledge management, knowledge engineering pulls it all together. I'm really appreciative for the opportunity. It reflects our entire office in Chicago and in Washington, and the team effort that's involved, and the support from the regents and the governors has been just exceptional. And we hope to continue to serve the fellows in this way. So thank you very much.
Well, thank you very much. As I've said during the conclusion of each of our last interviews, thank you and thank your team for all that you do for us, more importantly for our patients. It's a wonderful relationship, and I think it's a very unique one that you offer the American College of Surgeons and the patients who the fellows and members care for, based on your actions and the success, the recognition and success of those actions. So thanks.
Thank you. Appreciate it.